we'll be ending with a little bit about what is followed in our hospital. Coming to the overview on pulmonary hypertension, it represents a pathophysiological condition defined by elevated pulmonary arterial pressures that can arise from a wide range of cardiovascular, pulmonary, and systemic conditions. It's not a single disease entity, but it's a syndrome that requires classification for appropriate management. Coming to the hemodynamic definition of pulmonary hypertension is hemodynamically defined as mean pulmonary arterial pressure of more than 20 millimeters mercury measured at rest via right heart catheterization. This threshold was previously 25 millimeters of mercury, but now it has been reduced to 20 based on population normal values and risk associations above 20. Hemodynamic subtyping is a type of classification which helps in distinguishing pre-capillary pH, post-capillary pH, and combined pre plus post-capillary pH, which whose management is different and hence it directs the therapeutic strategies. These are the hemodynamic subtypes of pulmonary hypertension. There is pre-capillary pulmonary hypertension where the MPAP is more than 20, the pulmonary arterial wedge pressure is less than or equal to 15, and the PVR is more than 2 Wood units. This usually includes idiopathic, heritable, drug and toxin-induced connective tissue diseases, HIV, etc. As the etiological causes. Then there is isolated post-capillary pulmonary hypertension where the MPAP is more than 20, the pulmonary arterial wedge pressure is more than 15, and the PVR is less than or equal to 2 Wood units. This is usually because of the transmitted back pressure from the left heart, which usually has a normal pulmonary vasculature. So this is usually associated with valvular heart diseases like mitral stenosis or constrictive pericarditis or restrictive cardiomyopathy. Coming to the third type is combined pre plus post-capillary pulmonary hypertension, where the MPAP is more than 20, the pulmonary arterial wedge pressure is more than 15, and the PVR is more than 2 Wood units. This is usually a result of heart failure or late presenting shunts, or in case of chronic mitral valve disease. These categorizations are important to prevent inappropriate pulmonary arterial hypertension directed vasodilator therapy in patients who don't have that physiology or will not benefit from it. Coming to clinical classification of pulmonary hypertension, it is classified into 5 clinical groups with distinct etiologies, prognosis, and management strategies. And this is important as these 5 are going to be the way we are going to discuss our management. Group 1 is pulmonary arterial hypertension. Group 2 is pulmonary hypertension because of left heart disease. Group 3 is pulmonary hypertension due to lung disease and/or hypoxia. Group 4 is CTEF, and Group 5 is pulmonary hypertension with unclear or multifactorial mechanisms. This is the classification with their possible etiologies. In group 1, that is pulmonary arterial hypertension, we have idiopathic causes. These patients could either be responders or non-responders to vasoreactivity testing. We'll get to vasoreactivity testing in the coming few slides. They could also be because of heritable causes associated with drugs and toxins. Drugs such as methamphetamines, aminorex, and fenfluramine are most surely associated with pulmonary hypertension. And other drugs like amphetamine, diazoxide, leflunomide, cocaine, etc. have possible association with pulmonary hypertension. It can also be associated with connective tissue diseases, HIV infections, portal hypertension, congenital heart disease, and schistosomiasis. Group 2 is pulmonary hypertension associated with left heart disease. It is usually seen in heart failure, valvular heart disease, or congenital or acquired cardiovascular conditions leading to post-capillary PH. Group 3 is the one associated with lung diseases, the causes of which could be obstructive lung disease, restrictive lung disease with mixed pattern, hyperventilation syndromes, hypoxia without lung diseases, and developmental lung disorders. Group 4 is pulmonary hypertension associated with pulmonary artery obstructions, which is CTEF. And group 5 is pulmonary hypertension with unclear or multifactorial mechanisms such as hematological systemic metabolic disorders, fibrosing mediastinitis. Coming to a quick overview of pathophysiology of PAH, as this helps in understanding where the drugs or the pharmacotherapy actually acts. PAH is driven by vasoconstriction, proliferative vasculopathy, and thrombosis in situ, involving dysregulated endothelin, nitric oxide, and CGMP and prostacyclin pathways. This forms the basis of modern pharmacotherapy, including the use of drugs like ERAs, PDE5 inhibitors, SGC stimulators, and prostacyclins. So this image basically explains the above slides in a better form. So pulmonary vasculopathy is usually a result of intimal proliferation, fibrosis, vascular remodeling, medial hypertrophy, which is actually classified with the help of Heath Edwards classification as is visible from the middle section. So we have grade 1, which is medial hypertrophy, grade 2 with intimal proliferation, grade 4 with plexiform lesions, until right up until grade 6, which is necrotizing arteritis. So this in turn leads to right heart failure. As is visible from the bottom half of the image, there are three pathways that lead to this pathophysiology. The first endothelial pathway, which forms endothelin 1, which leads to formation of uh, proendothelin 1 to endothelin 1, which then binds to the endothelin receptors. This is intercepted by the ERAs or endothelin receptor antagonists. The nitric oxide soluble guanyl cyclase and CGMP pathway is intercepted by our sildenafil, tadalafil, the PDE5 group of drugs, whereas the prostacyclin pathway is accentuated by the presence of prostacyclins. Coming to the WHO functional classification, functional impairment is quantified using WHO classification, and this is important for understanding the timing and whether to use combination therapy for the patients or not. So we have class 1 where there is no limitation and during ordinary activity the patient is not symptomatic. Class 2 where there is slight limitations, there are symptoms with even ordinary activity. Class 3 is marked limitation where there are symptoms with minimal activity, and class 4 is symptoms at rest with signs of RV failure. So stratification by functional class correlates with survival and guides therapy intensification. Coming to severe pulmonary hypertension and chronic lung disease, severe PH in the context of chronic lung disease is usually defined as a PVR of more than 5 Wood units, irrespective of the MPAP values. This is clinically relevant because PVR correlates more closely with outcomes, RV function, and transplant candidacy than MPAP, especially in case of lung diseases. So severe PH identifies ILD, COPD patients who may benefit from lung transplant evaluation much earlier. Coming to the symptom-based recognition, the signs and symptoms of pulmonary hypertension. Initial symptoms may be exertional dyspnea, fatigue, reduced exercise capacity. They are usually non-specific, which is why patients present to us quite late. Progression may result in exertional syncope, exertional chest discomfort, peripheral edema, and signs of right ventricular failure. So, like I said earlier, the symptoms may progress from very non-specific symptoms early on, like dyspnea on exertion, dyspnea on bending forward, palpitations, hemoptysis, exercise intolerance, etc., to late more specific symptoms like exertional chest pain because of dynamic compression of the left main, hoarseness of voice because of Otto's syndrome where the left laryngeal nerve is going to get compressed, and shortness of breath, wheezing, cough, lower respiratory tract infections, and atelectasis. Coming to signs of pulmonary hypertension, the signs include central, peripheral, or mixed cyanosis, accentuated P2 component of the heart sound, the third heart sound being auscultated, systolic murmur of TR, and diastolic murmur of PR. The signs of RV backward failure are usually organ congestion in the form of hepatomegaly, peripheral edema, abdominal distension, raised JVP. And signs of RV forward failure are peripheral cyanosis, pallor, cool extremities, and prolonged capillary refill. The signs pointing towards underlying pulmonary hypertension include digital clubbing, which would indicate some cyanotic heart disease, fibrotic lung disease, or liver diseases, etc. Differential clubbing or cyanosis is seen in case of PDA and Eisenmenger syndrome. Auscultatory findings in the lungs or heart disease may indicate some underlying lung condition. Sequelae of DVT or venous insufficiency may indicate presence of CTEPH. And telangiectasia, sclerodactyly, and Raynaud's phenomenon may indicate group 5, where it is associated with systemic or rheumatoid diseases. Coming to ECG and chest radiography in pulmonary hypertension, ECG may show right axis deviation, right atrial enlargement, RV hypertrophy, or RV strain. However, these are non-specific and they have very limited sensitivity in the early stages. Chest radiography may reveal central pulmonary artery enlargement with peripheral pruning and right-sided chamber enlargement. Although supportive, neither modality is sufficiently specific or sensitive for diagnosis. So these are the typical ECG findings we see in pulmonary hypertension. We get P pulmonale, right axis deviation, RV hypertrophy, right bundle branch block, RV strain pattern, and prolonged QTC. This is a typical chest X-ray of a patient with severe pulmonary hypertension, as is visible both LPA and RPA appear dilated, and there is pruning. So pruning is actually defined as a dilated central pulmonary arteries with marked decrease in peripheral vascular markings, which appears like a uh, pruned tree. So basically, that's why it's termed as pruning. So these are the signs of severe pulmonary hypertension on chest X-ray. Coming to 2D echo, transthoracic echocardiography is recommended as an initial non-invasive screening modality when PH is suspected. So what we measure is the tricuspid regurgitation velocity, which when it is more than 2.8 meters per second, suggests elevated probability of PH, particularly when it is accompanied by other right-sided anomalies. So this is the usual flowchart that is used when it comes to identifying pulmonary hypertension with TRV. So if it is less than 2.8, then we look at presence of other echo PH signs. These other echo PH signs could either be from the ventricles, pulmonary artery, or the IVC. So from the ventricles, we measure the RV-LV basal diameter area ratio, flattening of the interventricular septum, and the TAPSE-SPAP ratio. For pulmonary artery, we measure the RVOT acceleration time, early diastolic pulmonary regurgitation velocity, and the PA diameters. For IVC, we measure the IVC diameter, which, if more than 21 mm with the decreased inspiratory collapse, is considered significant, and the RA area. So coming back to this flowchart, so if either of these are present, it helps in increasing the weight of diagnosis. If the patient has a TRV of less than 2.8, but these signs are present, then it is considered as a PH probability intermediate. If the TRV is between 2.9 to 3.4 and these signs are present, then the probability is considered high. If the velocity is more than 3.4 and these signs are present, then it is a high probability for pulmonary hypertension. In those cases, it is required to proceed with the right heart catheterization, and in other cases, it is required to continue with echo follow-up or consider other diagnosis. The other modality of management is of investigation is ventilation perfusion scintigraphy. VQ scanning is recommended for evaluation of suspected CTEPH and is more sensitive than CTPA, CT angiography for detecting chronic perfusion defects. A normal or near normal VQ scan is essentially used to exclude CTEPH. Perfusion abnormalities that correlate anatomically with proximal organized thrombus are the basis for operability assessment in case of pulmonary thromboendarterectomy. CTPA and advanced imaging. CTPA further categorizes vascular anomalies like webs, bands, and pouch defects, confirming chronicity and location of thromboembolic material. Other modalities like dual energy CT and digital subtraction angiography may be used in PH centers to map perfusion and optimize surgical planning. Imaging assists in helping us to differentiate whether we can operate, that is, the lesion is surgically accessible, it is more proximal, or lesions which are more distal that are more amenable to balloon pulmonary angioplasty. Coming to right heart catheterization, so this is utilized for definitive diagnosis. RHC is mandatory to confirm the presence of PH, determine its subtype, and guide therapeutic strategy. Hemodynamic measurements should include MPAP, pulmonary artery wedge pressure, RA pressure, cardiac output and index, PVR, and mixed venous saturation. The thresholds that we usually follow are pulmonary hypertension is considered when MPAP is more than 20. Sir, which slide are we at, sir?
Right. No, we are on CT pulmonary angio.
Is it okay now, sir?
No. I can't see right heart cardiac. It's got. Yeah.
Correct slide, sir. Right heart catheterization.
Yeah.
So the thresholds that we utilize to diagnose pulmonary hypertension are MPAP of more than 20. And pulmonary hypertension is also diagnosed with the pulmonary arterial wedge pressure of less than or equal to 15, plus a PVR of more than 2 Wood units. And post-capillary pulmonary hypertension is when there is a PAWP of more than 15. Distinguishing pulmonary artery hypertension from pulmonary hypertension because of left heart disease prevents inappropriate pulmonary vasodilator use, which may worsen pulmonary edema. Acute vasoreactivity testing. So this is a test when during right heart catheterization, there are certain interventions done in order to see if there is any improvement in MPAP or not. Acute vasoreactivity test to identify candidates for calcium channel blocker therapy. A positive vasoreactivity response requires an MPAP decrease of more than or equal to 10 millimeters of mercury, reaching an absolute MPAP of less than or equal to 40 millimeters with cardiac output maintained or decreased. So the interventions that are usually done or the agents that we usually use are either inhaled nitric oxide at a range of 10 to 40 parts per million, or we can use IV ipoprostentol, or we can use IV adenosine or inhaled iloprost. So when these are utilized, if the MPAP falls, if the difference in MPAP is more than or equal to 10 millimeters, or the absolute value is less than 40, then the patient is considered to be vasoreactive. Those patients benefit more from calcium channel blocker therapy as compared to other patients. And non-responders who deteriorate on CCB therapy must be changed into PAH specific therapy, which we will get to in a while. So coming to the risk stratification framework, the risk stratification stratifies patients into low, intermediate, or high risk, depending upon symptoms, exercise capacity, biomarkers, imaging, etc. To summarize, low risk status includes WHO functional class 1 to 2, who have a 6-minute walk test distance of more than 450 meters, a BNP of less than 50, RA pressures of less than 8, cardiac index of more than or equal to 2.5 liters per minute per meter square, and mixed venous saturation of more than 65%. High risk status is defined as functional class 4 with a 6-minute walk test of less than 165, BNP of more than 300, RA pressures of more than 14, cardiac index of less than 2, and mixed venous saturation of less than 60. So high risk classification may prompt earlier referral for transplantation evaluation or shunt based palliation. So since we mentioned 6-minute walk test, it is I'll just mention how it is usually done in our hospital. Basically, it's a 30-meter corridor that is considered, and the patient is made to walk up and down of it until the patient gets until 6 minutes or the patient gets fatigued earlier. The total distance is measured, and the SpO2 and the heart rate are measured. Normally, the distance is between 400 to 700. More than 440 is considered normal. If the patient is able to do less than 320, they are considered at risk for intolerance, and less than 165 is considered as severe disease. So this is just the image of the 3-strata risk stratification that has been released in the recent guidelines. It just entails everything that was discussed in the previous slide and helps us to identify and guide the further course of management for patients who fall into these categories. Coming to PAH management or group 1 management. So the definition, like we discussed earlier, was an MPAP of more than 20 millimeters of mercury, the pulmonary arterial wedge pressure of less than or equal to 15, and a PVR of more than 2 Wood units. These thresholds help in differentiating PAH from PH due to left heart disease and ensure proper allocation of vasodilator-based therapy. So the causes of these will include idiopathic, heritable, drug-associated, connective tissue disorder-associated, portal, congenital, and schistosomiasis associated forms of disease. Coming to diagnostic requirements, diagnosis of PAH requires exclusion of pulmonary diseases, left heart diseases, and CTEPH, all of which will also present with elevated MAP. So pulmonary function testing should be done to, that's a PFT should be done to demonstrate no more than mild impairment, that is FEV1 by FVC should be preserved, and DLCO should be mildly reduced, and HRCT should not show any extensive parenchymal disease. Plus, we must also do a VQ scanning to which should be normal or near normal to exclude CTEPH. Coming to first-line therapeutic strategy for PAH, initial therapy is determined by WHO functional class and risk category. High-risk patients will require early prostacyclin therapy along analog initiation. Reassessment should be done at every 3 to 6 months to determine whether therapy must be escalated or to continue. So the drugs we usually use are endothelin, the ones that affect the endothelin pathway are targeted by ERAs or endothelin receptor antagonists, such as bosentan, ambrisentan, and macitentan. And there are drugs that target the nitric oxide CGMP pathway, which are targeted by PDE5 inhibitors like sildenafil and tadalafil, or SGC stimulators like riociguat. Prostacyclin pathway is targeted by prostacyclin analogs like ipoprostentol, the trepoprostenil, and iloprost, and receptor agonists like selexipag. Prostacyclin is the only class which provides evidence for survival benefit, especially in case of high-risk disease. So, therapy is usually decided based on risk. Low or intermediate risk patients who have functional class 2 or 3 usually are initiated on ERA plus PDE5 inhibitor dual therapy based on baseline risk evaluation. High risk patients usually will receive IV or subcutaneous prostacyclin plus a combination of oral therapy. Prostacyclin therapy is initiated early to reduce mortality and stabilize RV function in patients who've got high risk. The vasoreactive subgroup, like I mentioned earlier, the vasoreactivity testing helps us to dictate whether to start calcium channel blockers or not. So, in case the patients with idiopathic, heritable, or drug-associated PH who demonstrate positive vasoreactivity, which show a MPAP reduction of more than or equal to 10 to less than 40 of with maintained cardiac output, may benefit from high dose of CCB monotherapy. Absence of vasoreactivity will mandate transition into guideline-directed combination therapy. This pathway avoids inappropriate CCB exposure in non-responders, which may be harmful. Sequentially, therapy needs to be escalated every 3 to 6 months using functional biochemical imaging and hemodynamic metrics. Persistence of intermediate or high risk features, that is 6 minutes walk test of less than 440, elevated BNP and less cardiac output of less than 2.5, mandates escalation towards triple therapy, often including prostacyclin. Failure to achieve low risk profile despite maximal therapy warrants a referral for lung transplant evaluation. Coming to role of transplant in advanced PAH, transplant referral is appropriate for patients who maintain high risk despite optimized PAH therapy and those with rapidly progressing disease. So indications will usually include WHO functional class of 3 to 4, a cardiac index of less than 2 to 2.2, RA pressures of more than 14, and persistently elevated BNP and 6-minute walk test of less than 300 despite fully optimized therapy. Both bilateral lung transplantation and heart lung transplantation are surgical options, but heart lung transplant is usually considered when there is irreversible RV failure or associated congenital heart disease lesions. Surgical intervention or procedures in case of pulmonary artery hypertension. Septostomy, that is balloon atrial septostomy, may be considered as a palliative or bridging procedure for severe PAH with refractory right heart failure or syncope by decompressing the right atrium and increasing the LV preload. Another method is Potts shunt, where we put a PA to descending aorta anastomosis. It is primarily considered in pediatric or refractory CHD associated pulmonary artery hypertension. These procedures are not permanent. They are just bridges to transplant and not alternatives in case of in contemporary management. That brings us to group 2, which is management of pulmonary hypertension with the cause being left heart disease. So this is defined by an MPAP of more than 20, a pulmonary artery wedge pressure of more than 15, which confirms the elevation in pulmonary venous pressures because of left-sided cardiac disorders. A PVR of less than or equal to 2 defines isolated post-capillary pH, whereas PVR of more than 2 usually defines a combined post plus pre-capillary pH. Hemodynamic differentiation is essential because PAH-targeted vasodilators may exacerbate pulmonary edema in whom there is already in post-capillary disease. The common causes are going to be heart failure with preserved and reduced ejection fraction, valvular disorders, and congenital or acquired left heart inflow-outflow obstructions. Surgical contexts include PH secondary to mitral stenosis, mitral regurgitation, aortic stenosis, and post-valve repair states. Persistent PH even after valvular correction may indicate that remodeling of the pulmonary vasculature has already taken place. Thereby, it is going to be a case of combined pre- and post-capillary pulmonary hypertension. So this image basically demonstrates the middle section of the image basically demonstrates the usual progression of how it occurs. First, there is increased LA pressure, which further leads to pulmonary congestion, which leads to remodeling like we had discussed in the previous slides, which further leads to right heart strain and further RV dysfunction. So it starts moving from the left ventricular phenotype more towards the right ventricular phenotype. And from no pH, it progresses to combined pre and post capillary pH. Diagnosis of pulmonary hypertension with left heart disease. Main modality of diagnosis is echo, which identifies the valvular heart disease, the LV systolic function, LV diastolic parameters, and left atrial enlargement. Right heart catheterization is used for diagnosis when it remains when it remains uncertain, particularly due to distinguish between pulmonary arterial hypertension and pulmonary hypertension because of left heart disease, when the pulmonary artery wedge pressure is 13 to 15 or volume status is complicating the interpretation. In case there is an ambiguity, we can do something known as provocation maneuvers, where we give a fluid challenge or exercise, which may show heart failure with preserved ejection fraction related elevation, and in PAWP in borderline cases. So how do we go about treating these patients? The treatment of the left heart disease is important to optimize volume status, control the blood pressure, and correct the valvular lesions. For heart failure with reduced ejection fraction, guideline-directed medical therapies are required to help in unloading the LV. There is no evidence supporting the use of PAH-targeted therapies in case of pulmonary hypertension with left heart disease, and they may increase the pulmonary flow and precipitate the congestion. Coming to surgical and transplant relevance in these cases, persistent PH even after successful valvular intervention is associated with worse postoperative RV performance and increased perioperative mortality. In severe cases, there may be an indication for heart transplantation or LVAD therapy, which may help in reducing the MPAP and convert inoperable cases to a transplantable status. Coming to group 3, PH because of lung disease and hypoxia. Group 3 PH is characterized by MPAP of more than 20, arterial wedge pressures of less than 15, and the PVR is usually elevated in the context of parenchymal or hypoxic respiratory disease. Severe PH in the lung is defined as PVR of more than 5 Wood units, which better correlates with mortality as compared to MPAP itself. Diseases like COPD, ILD, combined pulmonary fibrosis, emphysema, sleep apnea, hyperventilation disorders, and high altitude disease are included in this sector. This basically shows the progression from a mostly ventilatory related exercise limitation to a circulatory related exercise limitation. From no pH, the patient progresses to having a severe pH because of increased pulmonary vascular resistance beyond 5 Wood units. Diagnosis in these patients will usually include pulmonary function testing with DLCO reduction and HRCT to assess the parenchymal burdens and ABGs to quantify hypoxemia and hypercapnia. Ventilation perfusion scan is recommended to exclude CTEF due to overlapping imaging appearances in advanced lung disease. And right heart catheterization confirms precapillary hemodynamics and quantifies PVR, which influences transplant-related decisions. How do we go about treating these patients? The primary therapy would be to treat the underlying lung disease, oxygen supplementation for chronic hypoxemia, and pulmonary rehabilitation to improve the functional capacity. There is no role of PAH specific therapies in group 3, and it may worsen gas exchange by increasing the VQ mismatch. In selected ILD-PH patients, they may be considered for inhaled treprostinil, which has been shown to have some improvement in exercise capacity. However, this does not alter the transplant candidacy timing. In these patients, severe PH with PVR of more than 5 Wood units in ILD and COPD, there is an established indication for referral for lung transplantation evaluation due to the poor prognosis with medical therapy alone. Bilateral lung transplantation is favored in advanced lung diseases with PH. Single lung transplantation may be an option for select patients with COPD with moderate PH. So perioperative considerations for patients with left heart disease and patients whose cause of pulmonary hypertension is the lung disease. These both groups will have compromised RV reserve and may decompensate perioperatively due to hypoxia, hypercapnia, acidosis, and fluid overload. Positive pressure ventilation can worsen RV afterload by increasing the PVR. Thus, ventilatory strategies should aim for normoxia, normocapnia, and we should avoid high PEEP. Surgical note is that the risk stratification prior to lung resection or transplantation is very essential to predict post-operative RV failure. Group 4 is CTEF. CTEF is defined as persistent organized thromboembolic obstruction of the pulmonary arteries causing precapillary PH after at least 3 months of effective anticoagulation. Hemodynamic criteria includes MPAP of more than 20, arterial wedge pressures of less than 15, and PVR of more than 2 on right heart catheterization. The guidelines also recognize another entity, which is CTEPD, without the resting PH, where the symptomatic patients have chronic perfusion defects, but they have a normal resting MPAP. In these patients, ventilation perfusion scintigraphy is recommended as a screening test because of its high sensitivity for detecting mismatched perfusion defects. CTPA is used to define the lesion morphology, distribution, and surgical accessibility, whether with webs, bands, pouches, lesions, etc. So the usual diagnostic algorithm that is followed for CTEPH patients is as a part of PH workup, or when in a patient who's suspected to have CTEPH, we do a perfusion imaging in the form of a VQ scan, and we do an echocardiography. If in that there is a mismatched perfusion defects or there is a high probability of PH, then we go ahead and do further imaging, which is CTPA and DSA, and a right heart catheterization. Once it is confirmed, then we go ahead for either intervention through surgery or through balloon angioplasty. If the patient does not have very specific findings in both imaging, then we go ahead and do an exercise testing, which helps us in pointing us in the right direction whether imaging is required or not. Operability assessment for pulmonary endarterectomy. Operability is determined by the lesion location, whether it is proximal or distal, surgical accessibility, correlation between obstruction and hemodynamic severity, and patient comorbidities. Proximal diseases which involve the main, lobar, or segmental arteries are typically operable, whereas the distal subsegmental disease may be favorable for balloon pulmonary angioplasty. The pulmonary endarterectomy is a treatment of choice, which is potentially curative with normalization and major reduction of PVR. Pulmonary endarterectomy, it usually involves, PA usually involves bilateral endarterectomy under deep hypothermic circulatory arrest, allowing for removal of organized thromboembolic material down to the segmental and the subsegmental levels. Successful PA results in the marked reduction of MPAP and PVR with improvement in RV size and function. Residual pH even post PEA is defined persistent by persistently elevated PVR even more than 3 to 4 Wood units, and is usually associated with worse long-term outcomes. Balloon pulmonary angioplasty is indicated in patients who have inoperable CTEPH or have persistent or recurrent PH even after PEA. The procedure targets distal web-like or ring-like lesions which are unsuitable for surgical removal. BPA is performed as staged sessions to reduce reperfusion lung injury and has been shown to significantly reduce the PVR and improve functional class. This BPA is constantly being integrated into multimodal therapy and a multimodal approach towards treatment of pulmonary hypertension. Coming to medical therapy and multimodal CTEPH management, lifelong anticoagulation is mandatory for all patients with CTEPH or CTEPD. Riociguat is recommended for inoperable CTEPH or for persistent PH after PEA and improving exercise capacity and hemodynamics. Optimal management usually combines PEA, BPA as well as medical therapy and is usually individualized based on the person's anatomy and the person's response to therapy. So this is an image that basically shows us the various levels of disease and what the approach is. In the first part, in the first one third of the image, we can see that the disease is usually limited to the larger lobar and interlobar arteries. So it is amenable to surgery through pulmonary thromboendarterectomy. In the distal PA, which have much smaller caliber, in those areas, they are more amenable to BPA. Whereas in microvascular vasculopathy, where the size of vessels are less than 0.5 millimeters, it is usually preferred to do medical therapy in those cases. This is another image that shows the same as was explained in the previous slide. The main pulmonary artery, lobar artery, segmental artery, which is levels 1 to 3, they are usually amenable to thromboendarterectomy. Subsegmental levels or level 4 are better addressed with the help of BPA, and microvasculature is usually reserved for medical therapy. The size of the vessels from main pulmonary artery level of 3 centimeters go down to a microvascular level of 0.1 to 0.5 millimeters. So depending upon the size of the vessel and where the lesion is located, the therapy is decided. Group 5 is PH with unclear or multifactorial mechanisms. It usually is associated with hematological disorders, systemic diseases, metabolic diseases, CKD, and rare conditions like fibrosing mediastinitis. Hemodynamic profiles are heterogeneous and they don't actually fit neatly into pre or post capillary categories. Management is individualized and directed at underlying disease with no routine role for PAH targeted therapies. A small word about the ICU management in severe PH and RV failure. Acute RV failure results from increased RV afterload, reduced RV contractility, and impaired coronary perfusion. Hemodynamic targets include maintaining adequate preload and MAP of more than or equal to 65, and minimizing PVR by avoiding hypoxia, hypercapnia, acidosis, and by keeping high PEEP. Inotropes like dobutamine and vasopressors like norepinephrine are used judiciously, and pulmonary vasodilators may be added in select cases. Finally, mechanical support of ECMO may be considered as a bridge to recovery or a bridge to transplant. Heart and lung and heart transplantation is indicated in patients who have advanced PAH or CTEF who remain high risk despite optimized therapy. Referral criteria is usually functional class 3 to 4 with cardiac index of less than 2 to 2.2, RA pressures of more than 14, and PVR which is persistently elevated, and failure of combination therapy. Bilateral lung transplant is preferred for PAH and CTEF. Heart lung transplant is referred for irreversible RV failure or complex congenital heart disease. Just a small bit about the NH, what we follow in our hospital for management. For evaluation of CTEF, the first step is the echo, and there is an indirect measurement of severity by estimating the PASP using the TR gradient and the pulmonary acceleration time. We do a 6-minute walk test in all patients where more than 450 meters is considered as normal, less than 400 is considered risky, and less than 300 is considered as high risk. Right heart catheterization is done for all patients invariably. Here, as per the guidelines, PVR of more than 2 and and MPAP of more than 20 is considered diagnostic. In right heart catheterization, earlier we used to see the response to plain oxygen. Now it is seen with the help of inhaled nitric oxide or injectable vasodilator response. For pulmonary hypertension, the drug of choice in our center we usually use is riociguat, but we do use sildenafil, tadalafil in combination with other endothelin receptor antagonists. When patients usually present to us for the purpose of surgery, they would have already been on all of these medications, such as endoblock T, which is a combination drug of ambrisentan and tadalafil. And for post-op residual PAH, we usually utilize riociguat. To see for operability, especially in case of adult ASDs, we see a PVR change during right heart cath with these modalities. The role of INO in case of high PA pressures with the low PO2 and poor oxygenation intra-op itself, there is an indication to start INO. In case of reperfusion injury, INO first is attempted, followed by proning, and if last resort it is not reverting, then we can consider ECMO. This is just a summary slide of all the different types of pulmonary hypertension and the way they are managed according to the guidelines. Thank you, sir.
With you, but it was a very nice presentation. And I'm happy to see Dr. Basha Khan and Julius have give their
good morning, everyone.
Good morning, Basha. Jairaj here. Good morning.
Yes, sir. Good morning, sir. She has tried to cover in limited time a vast topic. She's covered most of the things. Based on epidemiology, I would like to say that still group 2 is the most commonest. Around, if we see 100 patients in OPD, around 60 to 70 of those are group 2 and followed by group 3. And unfortunately, in both these groups, there are limited treatment option except supportive therapy and treating the underlying disease. PH is still a rare disease, and we have made some progress, lot of progress in CTEF management group 4. Group 1, she has told about treatment options. Now we have a new drug, sotatercept, which acts on TGF beta pathway, and it has shown excellent result, and it is used from patients who are in intermediate to high risk profile. It is an injection which is once every 3 to 4 weeks, and many patients came off the list. Uh, Most likely it is going to be available in our country by this February. So it is going to be a game changer provided the cost is not prohibitive. So these are the things from my side, and vasodilator testing plays a key role, but once patient is in high risk profile and in group 1 also, uh, you have a lot of like HIV, we have cancer chemotherapy related. For those patients, it is not mandatory to check for vasodilatory testing. And even when there are 2 3 reasons. One is even if you have a calcium channel reversibility, only 10 to 15% people will have a long-term response. So even though in cath lab they show response, but long-term is still only 10 to 20%. And fortunately, one good thing is cost of oral pulmonary vasodilator and calcium channel blocker is more or less not so expensive in our country. Although we are lagging on IV and sotorasib, but these things are manageable. So these are the comments from my side, and definitely, as I said, RSC plays an important role to differentiate group 2, group 3 versus group 1. And we have to have a basic idea of epidemiology before we make every patient as a group 1 and start treating them with vasodilator. We are going to harm them instead of benefit. These are the things. Thank you.
Thank you, Dr. Basha. Julius, you have some comments?
Yeah. That was a really nice presentation, Ria. I think the understanding of the subject and the confidence with which you spoke was very good, and really happy to see that. Now, a few things which I want to point out is that your entire presentation is one from the 2022 ERS CSC guidelines. You don't seem to have referred to many of the other important documents which are, I mean, these are just constructive criticisms. I'm not saying your presentation was bad. Your presentation was excellent. So one of the important documents any pulmonary hypertension presentation should refer to are the World Symposia of Pulmonary Hypertension proceedings. So we have had 7 proceedings so far. At least the last 2 you should have looked up, in terms of making this presentation. One important aspect I want to stress is in terms of nomenclature, PAH and PH are not synonymous. We tend to use PH and PAH interchangeably, but that is not the right way of doing it. PAH refers to only the group 1 pulmonary hypertension. PH is an all-inclusive term. When that is one, and if you were to look at the World Symposia report from the 6th World Symposium, in the classification, there was a subgroup of CCB monotherapy responders. So that is a phenotype which may have a long-term response to CCB monotherapy, but that is no longer considered a big deal because, as Dr. Basha was saying, only a small number actually benefits from that, and most of them will benefit for a while and then again they'll stop responding. So, I mean, the vasoreactivity testing was only to identify that subgroup, and it is no longer considered a very important aspect of the PH cath. And one thing I think you did not mention is even though you gave the criteria for vasoreactivity testing, it is called the Sidborn criteria. So that needs to be kept in mind. These are things people tend to ask. Another aspect which you missed completely in the risk assessment is the reveal risk score. A lot of decisions about pulmonary hypertension is made after using the reveal risk score calculation. Online calculators are available. You put in the values and make the calculation. This is useful in terms of transplantation, prognostication. Again, you divide them into three groups based on the risk. Subsegmental CTEF. You were saying that is inoperable, but that is not. There are centers which do operate on subsegmental CTEF. When you look at the classification or the surgical classification in CTEF, almost everybody has subsegmental disease, but the classification as 1, 2, 3, 4 comes from where the disease starts. So if you have the type 4, that means there is no disease in the uh, artery proximal to the subsegmental artery. If it is purely at subsegmental level. So when you operate on subsegmental disease, you will have to raise the disease is not actually seen when you look into the pulmonary artery. It is beyond what you can see. It is beyond the segmental vessel. So you'd probably have to raise individual plain and normal endothelium at the mouth of the segmental vessels and trace it down based on imaging, trace it down into the subsegmental vessels and remove each subsegment and resect that. That it can be done with balloon also, but uh, don't say that it is not surgically accessible. There are centers which do that. We have also been doing it. In the earlier experience, we were not accepting subsegmental disease, but now we do accept them occasionally. And sometimes you have proximal disease on one side and distal disease on the other side. Distal means segmental or subsegmental. Those we tend to accept for surgery because at least part of it is resectable. And sometimes we do a combination of surgery and BPA electively, and we decide based on the disease if it is, which follows the other one. I want to have a word about coronary perfusion in pulmonary hypertension. You sort of referred to it in the ICU management. Now, we know that the coronary perfusion in the left ventricle occurs mostly during diastole, and in right ventricle it is a continuous flow because of the pressure in the muscle and the systolic and the perfusion pressure. When you have pulmonary hypertension, the right ventricle hypertrophies and becomes like the LV, and the pressure is high enough to stop the systolic flow during the cardiac cycle. So the RV perfusion also becomes like LV, and it will be purely in the diastolic phase. So it is important to maintain a good diastolic pressure in order to maintain good RV perfusion in patients who have right ventricular hypertrophy. So if you use drugs like milrinone and other vasodilators in order to improve the cardiac output, you will end up having a low diastolic pressure and the RV perfusion will suffer. So it is always good to use a vasoconstrictor like a small dose of noradrenaline to maintain good diastolic pressures. And the second thing is, if you have very low systemic vascular resistance, there is a steal from the right coronary artery, and the blood that should have gone into the right coronary artery would end up going into the systemic circulation. So it is important to maintain that. That is something to be kept in mind. And you also mentioned ECMO as a last resort in reperfusion edema. That is not so. You probably should use ECMO early, because if you put reperfusion edema is a very self-limiting thing. If you use ECMO early, the survival is very good. If you prone them and wait till the last moment, when you straighten them out, they arrest, and then you are looking at VA ECMO after arrest. There is a problem using VA ECMO in both lung transplant as well as in CTEP surgery. If you use VA ECMO and you stay on high flows or full flow, you are not providing adequate pulmonary blood flow. In CTEF, you have removed the endothelium in the pulmonary artery. And if you don't provide adequate flows in it, there is stasis, and your entire pulmonary tree will rethrombose. This has happened to us, and we've learned this the hard way. And in lung transplant, you are not revascularizing the bronchial artery circulation. So when you are taking blood away from the pulmonary artery, you're not providing adequate nutritive flow to the lungs. And particularly when you have a post-transplant lung which is having PGD, if you expect it to heal without having blood flow, it becomes really difficult. So these are, I think, about sotatercept you haven't mentioned at all, because that does not come in that guideline. It came in later, and we are expecting that drug to be released over the next few weeks in India. At the moment, it costs about 5 lakhs for an injection, And as Basha said, you probably need to repeat that injection every 3 to 4 weeks. So I do not know what the price will be when they actually start selling it here. But at the moment, these are sold as imported drugs from where you can import for a patient. So that's all I wanted to say from my side. Anyway, once again, very nice presentation.
Thank you, sir.
Thank
Thank you so much, sir.
you. Thank you, Dr. Basha and Julius, for your inputs and excellent comment. I did follow the last part that you said. What was that drug which was, and what is it used for?
It's a new pulmonary hypertension drug. Basha also mentioned that sotatercept.
Sotatercept. Okay.
It acts on TGF beta pathway,
Yeah,
which
it's
is a
different
new
from.
pathway besides the other three which we have known so far. And result-wise, it has proven to be exceptionally great results, and many patients who were on list came out of the list.
So, yeah. Ria, it was, as I said, it was a good presentation, but you should have focused a little bit more on the surgical aspects, as Julius was pointing out. And maybe for a general theoretical question, your presentation was fairly okay. But then subsequently, if you're going to be practicing cardiac surgery, then you will probably have to focus more mainly on the indications, the choice or the indications of the and choice of the patients that you will select for surgical management. You should focus more on that.
Yes, sir.
Uh,
Yes, sir.
any more comments, sir?
No, no, it is very good presentation, but when at express speed, so we couldn't actually get at some of the points. Previously, we used to do after 6 minute walk test, a cardiopulmonary exercise test. Is it not relevant, Julius? Now or you don't do that now, is it?
We do it when we have some suspicion. It is particularly relevant when we have patients with seated without
Yeah.
without pulmonary hypertension.
Yeah.
And another thing which is coming up is the exercise catheterization. So, as I said, if you were to read the World Symposium proceedings, there is a definition which has come up for exercise-induced pulmonary hypertension. Earlier, always we said these numbers were at rest, but the exercise numbers are also now accepted, and these are given in the sixth symposium proceedings. So, CPET is used. We have a CPET machine. We have been using it both for pulmonary as well as cardiac patients. Cardiac in terms of assessing the need for transplantation in people who are ambulant.
And among the palliative measures, you must balloon atrial septostomy.
Yeah, she mentioned that.
Even in babies more than 6 months, the balloon septostomy usually doesn't work because so those days used to have a blade septostomy, so that otherwise the borders are so thick, so it doesn't break as you pull the balloon down. Then
Yeah.
the other thing is between balloon atrial septostomy and modified PT, pot shunt. A pot shunt is probably better because the reduced oxygen, the blood reduced oxygen is going to lower limbs. Whereas if you do a balloon atrial septostomy, it goes to cerebral circulation also. I know Julius Davy has done few cases of a modified BT shunt. I also read that some cases they have inserted a small valve also in that. So during rest period, reversal flow doesn't occur. Also, I believe the intermediate results are not too bad. What do you think our results are? Are we still doing that?
So now I think most of the shunts are done in the cath lab. So
Yeah.
they've been doing that, and see, these are okay when the disease is not too bad in terms of RV failure.
Yeah.
If you have a CVP in excess of 15 or 20, doing these don't help. They just don't do well with that.
Yeah.
There is one patient who's had a cath lab based port shunt who is now listed for transplant.
Mm.
So I'm just thinking that it's going to be quite a difficult thing to control that shunt. It is not
Yeah.
like a surgically created shunt. This
Correct.
is a
How do they do a cath lab portion? What do
so
they do?
they do a CT scan first and determine which is the closest point between the aorta and the LPA. And
Hmm.
then they use guide wires in the aorta and in the PA and poke from one side into the other, and then put a
It. Mm.
the covered stent,
Mm.
that bridges from the aorta to the PA. So that is the procedure done, and these are pretty large shunts. So I'm just dreading the thought of going on CPB and having no perfusion anywhere, because the shunt
Yeah.
will entirely flow into the and then finally, even if but it's a heart lung transplant, you don't have to worry about the damage to the lung. But the problem is, until we can get control of the shunt, we won't have tissue perfusion in the peripheries. And I can't tell exactly where the shunt is. At least PDA and all that, we know where it is. So this won't be anatomical. And again, to repair it, it is going to be difficult because you have an 8 or 10 millimeter hole in the aorta also. So necessarily we need TCA in order to repair that aorta with a patch or something like that. So that's going to be quite a difficult challenge to deal with a catheter created port shunt. So we have been doing surgical port shunts. One of the institutions which has done a large number is Kokilaben. They've published their series of nearly 50 cases. They are doing it off pump through a thoracotomy. That is how we started doing, but subsequently we shifted to, out of necessity. One of the guys whom we were trying to do a port shunt arrested while inducing, so we had to do sternotomy and go on pump. Then we thought it is a lot easier to put a graft from the PA to the descending thoracic aorta within the pericardium by exposing the aorta near the diaphragm behind the heart. So that became a lot easier to do. Certainly, coming off bypass is a little tricky. You need to have all the measurements and numbers and play with constrictors and dilators and all of that for some time. But this is much safer to do. Can you otherwise, when you picture clamping a hypertensive PDA, or sorry, hypertensive PA with a partial clamp or a occlusion clamp, one, the clamp can slip anytime, and two, the pressure is going to go up tremendously and cause pulmonary hemorrhage. So some deaths have happened on the table when people do this. When you clamp, you suddenly develop pulmonary hemorrhage in the non-clamped lung because of acute increase in the pressure. So I think it is much simpler to do it on pump and be comfortable doing that. The other group didn't want to do it on pump because they want to do it without heparin.
Yeah, again, taking down the port shunt itself is a big exercise, and I can imagine, as you say, a catheter-based port shunt will be a nightmare. It's going to be a nightmare.
I remember that very well. There was a surgeon, Dr. Vasudevan, in Madras General Hospital, who used to do a lot of pot shunt for tetralogy, and I found that one of the most difficult thing to close, during open heart surgery for total correction. The other thing is, Juliet, many of these patients have severe functional TR.
Yes.
Generally, we thought we leave it alone. What
Yes,
is
sir.
the
No, in pulmonary, I mean, in CTF, we don't address the TR unless it's organic.
most
One
of
other
them
thing
come
we
down here.
didn't, yeah, other thing which we didn't mention is when you have these, yeah, you were saying about the valve, incorporating a valve into the port shunt. I think it's a bad idea because the valve, if the pressure is equal, then the flow will stop.
Mhm.
and if the flow stops, it's going to clot, regardless of what kind of anticoagulation you use. So it's probably best not to incorporate a valve into these shunts. And the one more thing which has come up is the atrial flow regulator, which is a device they use in the interatrial septum to keep the hole open. And there is a valved one also available. So you can decide what size hole you want, and it will maintain the hole at that size.
Again, you said you will use a graft between the PA and the aorta.
Yes.
What size do you use?
It's slightly smaller than the descending thoracic aorta at that size, about 1 or 2 sizes smaller than that.
How do you decide on that?
You see the descending aorta, you can tell.
No, but true. Then just like the BT shunt, you put a small shunt, it is not effective. You put a large shunt, it leads to failure. So this critical this thing is going to be difficult, isn't it?
That is why it's smaller than the descending aorta. But you need to have a fairly large flow. But when you have a large flow, again, there is general desaturation. It is not, see, the lower limb will have more desaturation, but even the upper limb blood also will be desaturated.
So this is the PTFE graft.
We use the HemaShield.
Okay.
Usually they're large, in the sense like it'll be 12 or 14 or something like that.
Okay. Thank you very much. We appreciate your comments, both you and Dr. Khan. And thank you, sir.
Thank you very much. Thanks. Bye.
Once again, Ria, it was a good